Good afternoon. This is Tom Goddard. I'm the CEO of Integral Healthcare Solutions, and I'm delighted you can join us for this webinar today on consumer safety and the URAC standards. It's everywhere. I'm joined by IHS's Senior Clinical Officer, Sue DeMarino, and our President, Lesley Malus Reed. And we're going to go through a selected group of URAC standards that seem to have consumer safety in mind. We invite you to look throughout all of the standards that apply to your organization to make sure that you're capturing all of the things that URAC cares about. But these are the ones that we really wanted to highlight today when we talk about consumer safety. So with that, I'll let my colleagues introduce themselves more fully than I did. And then we'll circle back around and start our review of these standards. Sue, why don't you tell us who you are and a little bit about your background?
Hi, I'm Sue DeMarino. I've been with IHS for 3 years, and prior to that, I was at URAC for 17 years. I am a registered nurse. I have a master's in healthcare administration, and I am really happy to be here today. Les?
Hi, I'm Leslie. I am the president. Yes, and I was at URAC from '97 till about 2005, where I met these characters, or 2003. And in 2003, I started working at Integral Healthcare Solutions, helping our applicants get ready for accreditation. I have a background from the Canadian healthcare system, and we are very excited to touch upon this standard, this theme of standards today that seems to go through all of the modules. We are going to hope to reach out to a broad spectrum of applicants and modules there. Tom?
Thank you, Lesley. And very briefly on my background, before I founded this firm, I was Chief Operating Officer and General Counsel at URAC, and naturally a whole bunch of jobs before that. And my educational background is I have a law degree and a PhD in industrial organizational psychology. So we're going to start with a cluster of 4 standards in the core and farm core modules. We'll leave the pharmacy specific stuff for later in this broadcast, but we'll go strictly with 4 standards at the outset that are in the core module. And we'll start with Core 24, and I'll toss this one to Sue. Sue, what does Core 24 have to do with consumer safety?
Well, Core 24 has a requirement that anyone who's consumer facing must have a patient safety quality improvement project. And sometimes this scares organizations. They're like, oh my goodness, what am I going to do for patient safety? So I wanted to let you know that URAC's interpretation of patient safety is pretty broad. And as long as you can make an argument on how it applies to your program and your population, typically they accept that standard. Some examples that we see, like in the pharma space, error reduction is a really good one. If you're talking about health it might be your access to service. It might be an expedited appeal turnaround time. So you have to look at your opportunities for improvement. So look at all of your metrics, your dashboard, to see if you've identified anything that you would like to improve, and you can go from there. There are some resources, and if you go into your program guides that URAC provides, they give you a whole list of resources on where you might be able to get safety quality improvement projects.
And Sue, if I may ask you a question, some of our folks are health plans, and they're already doing projects for HEDIS, projects that they have to do in the health plan. Are those accepted by URAC as well?
Yes. The health plan standards require that all of their QIPs be clinical in nature. And if you're doing things like, mammograms, diabetes, things like that, you can tie that to patient safety, and certainly one, if not all of those clinical programs will relate.
And what happens?
So this is a distinct requirement from the clinical requirement. So it sounds like this is a subset of clinical. Is that a fair characterization? We got clinical quips, and then this says one of those has to be patient safety in addition to being just clinical.
Right, and they can identify which it is, and that's fine.
All right. Thank you. Let's roll on to core 32, the senior clinical staff responsibilities. What does this have to do with patient safety?
Well, in that standard, the senior clinical staff person has to be responsible for all the clinical programs within the organization, so that your job description has to clearly describe that that's one of their responsibilities, and then your policy would reflect how that's being done. Like, how are they demonstrating that they're responsible for all the clinical programs? Do they have final review over clinical policies and procedures? Are they the person that's signing off on the, for instance, in Health are they the person that's signing off on the clinical criteria? The other piece to that standard that's really important, then really relates to patient safety, is having the appropriate clinicians making decisions about services that they're going to receive. So how can a plan demonstrate that they're in compliance with that? One way is for the senior clinical staff person to review clinical job descriptions, to be involved in the interview process, to do auditing on the clinical staff, or designating that responsibility to someone else and then reviewing the findings. Those are all examples on how the senior clinical staff person can have oversight of the process and ensuring that they have the right clinicians making those decisions.
What do they mean by clinician or the right clinician? What is that?
The appropriate clinicians. So for instance, if you had a behavioral health program, you'd want to make sure that the clinicians had training and experience in behavioral health. You wouldn't want a gerontologist to be the person making those decisions on behavioral health, right? So it has to make sense for the population that's being served. The specialty matching, that's very specific. That's another standard in and of itself.
Yeah, so for another day, maybe that's next month's topic. So
okay, there you go.
Thank you. The next one we wanted to talk about is Core 33, which is the basic financial incentive standard. To paraphrase it, Core 33 says if you have a system of financial incentives that is related to consumer utilization of healthcare services, then you need to have mechanisms in place to make sure that no harm comes to consumers as a result of that financial incentive mechanism. Now, for most of you watching this webinar, that's probably going to be not applicable at all. If you don't have any, you may have financial incentives, let's say, related to your company's profitability or related to certain quality of performance measures that don't relate to consumer utilization of healthcare services. And if that's the case, then all you'll want to do is prepare a fresh attestation on company letterhead and signed by a senior official in your company that says, we don't have any financial incentives that relate to consumer utilization of healthcare services, and that standard goes away. Now, for the few of you who may have an applicable financial incentive, then you'll need to document and demonstrate through that documentation that you have a mechanism to ensure that looks at things like underutilization or utilization patterns, perhaps overutilization, to make sure that there's nothing going on with those financial incentives that is impacting consumer utilization of healthcare services in a negative way. You'll find this in some quality programs and elsewhere. In fact, this is a good point, that what we need to make sure of, if it's not applicable to you, it's not just an attestation that URAC will accept. It used to be that they did accept just an attestation, but now the interpretation is to submit both an attestation and a policy and procedure that says we're not doing this. And I can see why URAC would do that, because an attestation doesn't bind the organization over time, whereas a policy and procedure does bind the organization over time. You have to change the policy and procedure to allow for financial incentives. And so it kind of makes sense to me why URAC would change its documentary requirements. What have I left out on this?
Well, for those of you who have worked with us, just so you know, these are some of the things that we provide templates for. So we have templates that will help you come up with the right language to be able to make a clear statement that your organization doesn't provide incentives based on a consumer's utilization of care that could negatively affect their health. So we have both an attestation and a policy and procedure embedded in our platform called Goldfinch. I don't know if you want to take a minute to talk about that, Tom, but these are some of the tools that we have to offer you.
Sure. Thank you. I'll be happy to spend a second on this before we go on to the next standard. Oh, by the way, folks who are watching live, you can ask us questions. You can see at the bottom of your screen, at least on the bottom of my screen, it says ask a question. You click on that and we'll see if we can answer your questions. So please feel free to do that. You can always say something nice in the Say Something Nice box. We like it when you say something nice, but give us some feedback or some questions, and we'll do our best to address them. Lesley mentioned Goldfinch. We'll probably mention it one or two times later on. And just for those of you who haven't interacted with this is a proprietary piece of software, online software, that helps us and our clients navigate the complexities of a accreditation process, whether it's URAC or ACHC or VIPS or Joint Commission Specialty Pharmacy standards. We can do we provide all of our resources in there, like the templates that Lesley was talking about. We have our own interpretive language. We have the accreditation organization's interpretive language. Plus, it's a secure environment for our clients to send us documents, have us review them, score them, give comments, and manage the entire process from gap analysis through mock desktop review, through mock validation review, to use the URAC model. And we adapt it for the other accreditation organizations that we work with as well. So enough about Goldfinch. Let's dive, that was actually a word from our sponsor. Let's dive back into our standards. The last of the core standards that we want to talk about in this context is Core 38, the Consumer Safety Mechanism. I'll throw this to Lesley, and I'll apologize to all of you. There's a technical issue with her channel that makes her have to yell in order to be heard by all of us. So, we have yet to figure out how to fix that. So we'll ask your understanding and forgiveness. Lesley, yell away.
So this standard, it requires a policy, and it also requires a lot of training to make sure that staff know what to do. But let's break down what URAC is looking for. They're thinking about, first of all, a distressed caller. They think about more than that, but in their definition of a distressed caller, they're thinking about somebody who might call in who is in clinical distress, such as having a heart attack, somebody who's calling in who is going to harm others or harm themselves. And URAC expects your policy and procedure to say something very specific. They want to make sure that the individual on the phone stays on the line at all times, never places the person on a hot, warm, cold transfer at all. They're always going to remain on the phone while they flag a second colleague. So if they're sitting at home as their remote user, they need instant message. And they will flag the second colleague to call 911. They will remain on the phone with this individual until 911 arrives. And this is a really good thing to go over with all of your staff who could potentially be interviewed during your on-site review to ensure that they can tell the same story. We recommend that you go over this maybe 2 weeks before you're on site. So certainly we want everybody to know about it. We want everybody to hold things up in their desk, such as, well, not everybody, but we're hoping to give people tools, because when they do get this emergency caller, they might panic. So it's always a good idea to have a red card or a flag or even a stop sign with some of the basic information on it to give people notice of what they need to do, the steps they need to take to be able to address this 911 caller. What we don't want to see is during the on-site for the person to take open the policy and procedure and start reading it. We're hoping they're going to be able to tell the story. They won't get dinged for having that policy and procedure, but we're hoping everybody can tell the same story. Then there's other types of consumer safety mechanisms, clinical drug or medical device recalls, and clinical threats. So these are all examples that you should be addressing in your policy and procedure, in addition to that distress caller that could help to meet this standard. And it will, again, mean different things to different programs. So to add to that.
And I just posted for you some resources that you can use for consumer-specific quality improvement projects. So I don't know if you can see it on the right-hand side, the leapfrog. Pardon me?
Not yet.
Okay, maybe I didn't press it.
There it is.
Okay. So there's some examples of where you might go to get information on quality improvement projects. Again, I would tell you to look at your metrics, to look at the, like any of the measures reporting that you might have to do that might help you identify a quality improvement safety quip, things like that.
The only thing I'd have to add to this standard is that there's a certain category of consumer safety threats that are within the scope of this standard that I would call the unknowable. You know, the kind of threat that you can't anticipate. What do you do with that? As long as there's a mechanism in place to elevate the issue to an appropriate level person to handle it, if your frontline staff doesn't have the particular training appropriate to resolve that issue, just have an escalation mechanism, let's say to the chief clinician in your organization or other senior executives, so that everybody has a clear idea of what do you do with a consumer safety issue that you've never seen before and never thought about. Escalate it to somebody who might be able to handle it. Leslie.
You know, one more thing. I said all staff earlier, and the issue is that we expect that really it's going to be your frontline staff who have interactions with consumers, to whom the scope of the standard is supposed to be limited to. But I'm going to tell you, in my experience, I was once at an on-site where a consumer call kept getting transferred to the boardroom where us reviewers were. And unfortunately, because of that instance, they have now required that all staff, whether you're in credentialing or IT, they expect your medical director, your HR person to be able to answer this question should they get into a circumstance where there is some caller on the other end in some kind of distress. So please do ensure that your training will address all staff.
That's a good point. In fact, I've heard that story enough times, including quite recently when I was doing a mock validation review for one of our clients, that they have been in a conference room, and as Leslie's example shows, and a consumer got through to them, a phone that you wouldn't expect a consumer to find. So yeah, really everybody's got to get trained on this one. So we just had a question before we move out of the core realm. We had a question submitted, which I'll just read. Could you please talk a little bit more about consumer safety QIPs, quality improvement projects? If the plan doesn't have performance issues with decision turnaround times, et cetera, what are the possible topics? And then what interventions are adequate?
Well, as when Leslie was punting the previous standard to me, I thought she was asking for me to comment on the question. So I've already said that I've provided resources for you on the right-hand side of where you can go to get quality improvement project ideas and information. As far as adequate interventions, it's going to depend on what your issue is. So for instance, what most organizations will talk about is how they identified the problem and then what steps did they have to do to mitigate that issue. So did you have to do auditing to identify that you have a problem? Did you have to retrain staff? Did you have to revise policies and procedures? Did you have to put in new workflows? Things like that. Those are all examples. What outreach do you do to the consumer? Things like that. URAC doesn't tell you what those interventions should be. It needs to make what you need to be able to provide to URAC is how it relates to the module, what the issue is, and then what you did about it.
I've heard that described as passing the giggle test. I mean, if you have a quality performance issue, and if you propose an intervention that is quite obviously unrelated, so unrelated as to cause the people in the room to giggle about your intervention, you have not passed the giggle test. So as long as there's a logical connection between what your intervention is and what you're trying to accomplish in your quality improvement project, as Sue said, there's likely not to be any looking over your shoulder as to what you've chosen as an intervention. Now, with one caveat, if this QIP is several years old and you've been using an intervention over and over and over and seeing no results from it, URAC might say, you might want to try a different intervention. This one is not cutting it. And it may not be even the problem with the intervention. It may actually be a problem with data leakage. You might be, there might be things outside of your control that are impacting the data in ways that are rendering your interventions useless. So if you do have old QIPs and they're just not working, you might, for URAC's sake, you might want to double check and revisit the choice of interventions. Hopefully that helps. And that's, yeah, Sue.
I was just going to add, and if you're not moving from your baseline to your goal, you need to be doing a barrier analysis to see, okay, is this anything that you can even impact? And at the end of the day, you may want to change your goal. You may want to, you may say, we can't make an impact. There's so many variables out there that are impacting our ability to have any influence on this QIP that we need to close it. And URAC's okay with that. Yeah. But then you remember, you have to have these QIPs going at all times. So for instance, a health plan has to have 3 going at all time. All the other modules that are required to have QIPs have to have 2 going at all times.
Great, thank you. And that's from Elizabeth Hayes. Thanks so much for your question. I really appreciate it. There's just one set of one standard in both the plan, health plan and health network that directly deal with consumer safety. And so I'll take those. They're plan or PNM 17 and NM 17. So these are in the network management module. And I have always called this, in the 20 years I've been interacting with this standard, I've called this the scary bad doc standard. Although it's much broader than that, but so this deals with participating providers. And it requires that your senior clinician, your medical director, whatever you want to probably call in your organization, a medical director, must be empowered to deal with the situation where he or she comes in contact with information that is persuasive that a provider in the network is putting patients, members of the plan, at risk of serious bodily harm and the like. So what must that empowerment look like? Well, first of all, the medical director must be empowered to, right away, without having to check with the credentialing committee, suspend that provider's termination. Once he or she is convinced, based on the evidence in front of them, that this particular provider does in fact pose a risk, yes, even if there's more investigation that obviously would need to be done, if he or she is convinced this is a dangerous provider for our members, the medical director must be empowered to suspend that provider from participating in the network. So that's this first step. When I was a reviewer, the closest any health plan came to missing that standard right there, which is a mandatory element and always has been, is when the medical director didn't think he had that authority. You know, the policy said he had the authority, but the medical director didn't think he had the authority. And so, you know, I asked the question 2 or 3 different ways, and ultimately he got to the answer that he needed to get to, which is, well, in that situation, if I were convinced, I would immediately, and immediately is the key word, immediately suspend that provider's participation. So that's the first requirement of that standard. The second requirement of that standard is that the investigation must be expedited. Your policy has to explain what that means, and in actual fact, your organization has to move expeditiously to investigate this. Because, so think about why that is. Since you've already expeditiously suspended the provider, what is this clause about expeditious investigation? Well, that's for the provider's benefit. What if it's the wrong provider? You know, you want to find that out fast as you can. And so this requirement this second requirement of NM 17 says the health plan or health network, have to investigate quickly. And then the third component, and this is probably the most frequently missed component or misunderstood, is that you need to give this provider the same kind of due process that you give other providers who you've terminated or changed their network status. Now, the previous network management standards, 14, 15, 16, deal with various situations around dispute resolution with participating providers. So read those carefully and make sure that any provider that you terminate or suspend under this standard, NM17, has access to the appeals rights of NM15, which is most likely the most likely applicable standard. And over the years, we've had a number of clients who when we first got there, their policies said there are no appeal rights for folks in this situation. That's just not that's not the URAC standard. There definitely are appeal rights, and they've really pretty much got to be the same ones that applied under NM15 to any other network provider that you suspend for quality of care or professional conduct reasons. What did I leave out?
The example we used to use for this was the Michael Jackson doctor. So you want to be able to, and of course that's dating us. It was a long time ago, but we all learned about it through the news. So it's not something that's going to come up through recredentialing, though it might, or through the MPDBQ or the licensing board. It's going to be something that you're going to learn through a newspaper article or the news that you want to be able to take care of, and then give yourself the time to do due diligence and really investigate, was this the provider who is Richard Smith III or Richard Smith II? And that's really why this scary bad doc, who we haven't learned about through a good resources to check NPIs and social security numbers and provider IDs, needs this due diligence to make sure we have the right person.
Yeah, in fact, the first time I ever encountered a scary bad doc situation, even before I worked at URAC, I was the general counsel of a health plan in the Washington area, and at my desk first thing in the morning reading the Washington Post, and there was an article about a doc in Alexandria who had been led away by police for all sorts of bad practice, dangerous practice issues. And my first reaction was to call out to my executive assistant and say, Liz, what do we do with this? You know, that's the situation. As Lesley said, you're going to learn about this any sorts of ways. Your network management, your provider relations department needs to be alerted as to what to do in a situation like this, because it might be that on a field inspection, a kind of a routine visit from your provider relations staff to a provider's office might reveal, oh my goodness, look at this waiting room is not just filthy, it's actually dangerous. And it could be come from all sorts of different sources. You've got a wide range of folks who need to be trained on how to get this information about a scary bad doc or other provider into the right hands so that you can start doing this. Start doing the appropriate procedure. Now, this is very rare. This kind of thing is very, very rare. So it might not, you likely won't have an example to show the URAC reviewers. You might, but the odds are that unless you're a rather large health plan or health network with many thousands of providers, the odds are against you ever seeing this. But if you do, just be sure that you document how you've handled it very well throughout the process. And if you don't, at some point in the process, including the desktop review process, you may be called upon to submit an attestation that say we have never had it. You might submit the policy for desktop review that explains how to do this, and with that an attestation that says this health plan has not had an example of this kind of suspension in the accreditation period. Alrighty, that's probably enough about that. The real juice of these issues can often be seen in the utilization management world, and we'll start with HUM 28. And that's the prospective review patient safety issue. This is found, I'll set this up, this is found in the HUM standards, health utilization management. It's also found in the health plan version of that, the PHUM standards as well. So, so I'll turn it over to Sue to talk about prospective review patient safety.
Okay, great. Well, in this standard, URAC requires that you have a mechanism to address a safety issue that is recognized during the prospective review. So what type of an example can I provide for you? Let's say you get a request for a right knee amputation, below the knee amputation. And when you get the records, it's all the records talk about a left knee problem all the way through. Well, okay, you need to do something, because as an organization, you've identified that they may be operating on the wrong leg, okay? So what the standard requires is that someone take action and that you work the problem until you have some resolution. You as an organization get to define what that mechanism is. If you're a UM company that is contracted by a health plan to do the utilization management review, your process may be to notify the health plan. Or if you are the health plan and it's your UM company, it may be that it's taken to a peer reviewer, that peer reviewer calls the doctor's office, the surgeon's office, and make sure that they have the right information. Was this wrong information that was submitted for the review, and come to resolution. Now, URAC does not require you to document the absence of a prospective safety issue. You only have to have a mechanism to document that there was a safety issue and what you did about it. Some organizations put it in their notes section in their records, but I will tell you it's really hard then to pull that information out. Many organizations will develop a spreadsheet, a template, or some way of tracking these prospective safety issues so that they can then provide an example to URAC during the interview process. I will tell you, this is one of the questions that we as mock reviewers, as we're getting organizations ready for accreditation, will ask all the folks who are involved in prospective review. But this is a question that the URAC reviewers will ask. And this is probably the question that gets the deer in the headlight look from the person that I'm asking the question. Like, they look at me, they have no idea what I'm talking about. So it's really important that you train your frontline staff who are your initial clinical reviewers who are doing prospective review, and also your medical directors on what their responsibility is to handle that, and then making sure that you have clear documentation of those that you have handled it, and did you meet your protocol. And again, like I said earlier, you can decide what that mechanism is, how that process looks, but just as in this standard and any other URAC standard, anytime you see the word mechanism, you have to define what that is. So your policy needs to clearly define that mechanism.
So
Let's see.
Sue, what would a question, could they expect to hear in that question? Just so it would trigger, because we get ready for the reviews, we get very nervous. What would likely be a question that you would ask casually to the frontline person you're sitting with?
Well, during the file review, they'll say, was there a prospective safety issue identified? And if the person that's driving the review looks at the reviewer like, oh, what are you talking about? They're going to start digging. But they will also ask, when they bring all the staff together for the interview, they'll say, tell me about what your mechanism is to handle a prospective safety issue. Give me an example of one that you've had. And then oftentimes, sometimes the disconnect, the frontline staff can answer the question, but the medical director or the peer reviewers aren't familiar with it. They handle it on a day-to-day basis, but they don't recognize the terminology. So you want to make sure that they recognize the terminology, that they understand that it's a mandatory standard and it can derail your accreditation, your full accreditation.
So it sounds like training standard would be really critical here, and I'll take that opportunity to do a commercial. If you are grappling with how to train your staff on the appropriate URAC standards, our company developed a few years ago something called a credit train, and you can go to our website at integralhs.com. You don't even need to be a consulting client of ours. You can go straight in to our training page on our website, scroll down until you get to a credit train, and click on the link there, and you can start training your staff. The nice thing about a credit train is it's built around the Core 27 requirement that you train your staff in the only in the standards that apply to them. So you don't want to train your IT people on if you're a pharmacy, the patient management requirements of a specialty pharmacy. And so a credit train allows you to kind of target. All right, we're going to, and it also helps you target. Well, I don't need to train my frontline staff on the same things I need to train my management staff on. And so we can also segment your staff that way as well. So the managers in quality management get trained on the management appropriate level training, and frontline and the call center gets trained just on that. And I'll post the link to the website in just a minute as soon as I stop yapping. So I'll toss it back to Sue. Anything else on HUM 26 that you'd like to talk about?
Well, Stormy has asked a question, and it's, what do you do when from month to month you have a chronic abuser of, and you've identified a patient safety issue? My recommendation to you there is to notify the health plan that you're contracted with. It almost becomes a quality of care issue if you identify that there's problems month after month. So I would take it through that process. Tom, do you want to speak any more about that?
No, I think that's perfect. That's a perfect answer. Okay. So anything else on 26 before we move on to the next standard?
I do not have anything unless we get another question. Let's see. I see another question asked. Let's see what it is. Does URAC define safety issue? No, they just talk. They talk about, I'll look and see if there's a defined definition for safety issue. I don't think it is. I think it's where you can identify that there's an immediate harm to that patient. and having doing something to prevent that from occurring.
All right. Thank you. And thank you, Stormy. Good to see you there. Let's move on to HUM 33, non-certification appeals process. What does this standard have to do with patient safety?
Sure. Health UM 33 and 38 go hand in hand, and it's all about the expedited appeal process. So if you have urgent requests or for services where the patient could be, it could impact their health or impact their ability to maintain functioning, things like that, then you have to have an expedited appeal process. And if you are not contracted to do expedited appeals, then I would tell you you need an attestation that you're going to provide to URAC that says you do not do expedited appeals because you're not contracted, and you can strengthen the submission of your documentation for this standard, if that's the case, by having an excerpt from your contract that states that the health plan will retain the expedited appeal process or the appeal process in general. The other piece about expedited appeals that is very important is the turnaround time. It's 72 calendar hours. I will tell you that organizations struggle with this standard over long weekends, holiday weekends, where they get the request on Friday and they're off Monday because it's Memorial Day or Labor Day, and they don't do the review till Tuesday. You've exhausted your 72 hours. It's 72 calendar hours. This includes the verbal notification requirement. And what we typically see when I'm doing the audits, what is usually missing from the documentation for expedited appeals, related to expedited appeals, is the documentation of that verbal notification. After you provide that immediate notification to the member, to the provider, then you have 3 calendar days or 3 business days, I'm sorry, to provide the written notification. But it's really important for you to make sure that you're paying attention to the clock. And the other thing that's important to know is that there are a lot of state requirements that are tighter than the 72 hours. So you need to pay attention to the state laws to make sure that there's not tighter time frames. I believe there's somewhere in New England, I don't remember the exact state anymore, where the turnaround time was 4 hours if the review was received by 2 p.m. on any day. And organizations were really struggling to meet this turnaround time. And they were setting a precedent where they were auto-approving those because of the turnaround time requirements. But then that sets them up for appeals for folks that received, that were sent in timely in order to do the review, like say, in the morning of the day, and it's turned around within the 72 hours, and it's the same type of case, and they approve one and deny another. So you have to be careful about setting those precedents as well. Again, having an expedited appeal process, if it involves urgent care or care could be the health of the patient or their functionality could be compromised without that decision, and then paying attention to the 72-hour turnaround time and making sure that you have that notification, that immediate notification, well documented.
So anything else we should talk about on the health utilization management front, or?
No, I think I'm good. I don't see any questions related to that. So
I think we're good. So, let's start. I'm going to pull Lesley, and we had a little technical difficulty, and so while Sue's talking about the next standard, I'll do that. This next cluster of standards, which is our last cluster of standards, is all from what we call the pharmacy suite. Some of them are in the specialty pharmacy standards. Some of them are in Pharm Core, maybe PBM. But this is for all of you in the pharmacy world. Pay close attention because that's where we're going.
Okay.
Take it away, Pharm Ops 12, the
All
handling and removal of unacceptable meds.
Okay. All right. So this standard, URAC identifies for you what they consider to be unacceptable meds. Everything from counterfeit, adulterated, recalled, expired, damaged, misbranded. All of those are examples of what URAC calls an unacceptable medication. And then in the next part of the standard, it gives you different scenarios in which you have to address the handling of that unacceptable medication to those scenarios. So an example of that is who receives the notice from manufacturers or the FDA of an unacceptable med. My advice to you, so there are, I believe, 8 types of unacceptable meds that you have to address, and I think there's 6 or 7 scenarios. So the most expeditious way to handle this standard is in your policy, define unacceptable meds to include all that is in the list that URAC has provided, okay? And then you take each of the scenarios that URAC provides where you have to address how it's handled, and you reference it from an unacceptable medication perspective rather than having a policy for recall, having a policy for counterfeit, because then it becomes so unwieldy that it's really difficult then to demonstrate compliance. So the most common mistake is sometimes folks think only about a recall when it comes to getting information from manufacturers or the FDA about a medication. And so they'll only address the recall process. So then you'll get this long RFI from URAC for this standard that goes through each of these types of medications, and they'll ask you to provide information on all the different scenarios. So again, in your policy, define unacceptable med to include all the meds that URAC has defined as unacceptable. And then when you're writing your policy, write your policy as all-inclusive by just saying, unacceptable meds are handled in this way. This is how we notify our staff of an unacceptable med. We have stand-up meetings followed by emails to the staff. Well, how do you handle unacceptable meds when it's in the shipping process, or you're checking lot numbers, you're doing outreach to the patient and the provider on unacceptable medications. You're letting them know how to return them if you can accept a return, or how to destroy them. Where are they quarantined? So you quarantine your unacceptable medications here. If they happen to be hazardous drugs, you take those hazardous unacceptable meds and it's placed somewhere special. So you identify the process from that unacceptable perspective. Okay? I think that's all I have to say about unacceptable meds, but this is one of those standards that will get an RFI back if you don't follow our advice on how to handle it. There's just too much.
This seems like a good opportunity to talk a bit about specificity, since that was one of the main points you were making about how to kind of walk through, here's what we do in this situation, here's what we do in that situation. That's just a general principle for policies and procedures in the world of URAC. Imagine this, you've got a new employee who's supposed to do this thing, and they get a policy and procedure, and all it says is, the manager of such and such is responsible for doing this thing, and doesn't explain how to do it. URAC has an expectation that your policy and procedure, particularly the procedure part, explains to the staff member how to do the thing they're supposed to do. So be specific and walk through, as Sue described, step by step what needs to be done.
And I agree with you, Tom, but I think there's even greater emphasis in the pharmacy standards.
Yeah.
They want to have the very, very minute details. Who does it? Where's it documented? How's it done? How quickly is it done?
That's right.
If you can answer those questions in the pharmacy standards, you usually do well on your submission to URAC.
That's right. That's right. That's why kind of just submitting some consulting firms templates without getting down into the weeds with your staff and saying, this is how we do it at our pharmacy. If you rely simply on templates, then without doing that, then that's probably the single most common reason for denial of accreditation for a specialty pharmacy is that some consulting firm says, we got templates for that, just use these. And we have been told over and over by veteran pharmacy reviewers that that's the most common problem that specialty pharmacies face. So, make sure that you're specific. Let's move on to Pharm Op 15, which is proactive risk assessment.
Okay, so this standard is in the standard that deals specifically with the quality of the program, looking for ways to monitor things like errors and to prevent errors. And the proactive risk assessment, this is something that is done not as a result of an error, but to help prevent an error. And if you go out to, if you look at FEMA and their failure mode and effects analysis, you will find a document that is very long, very thorough, and will take you a great deal of time to fill in and address all the pieces that are required. IHS has created a template that's basically 3 pages long that URAC has accepted and that addresses all the things that URAC is looking for. So it's when you get a new drug, a new piece of equipment, you're looking at that drug, you're looking at that equipment to see how you can prevent an error from occurring. And then knowing what you know about your organization, how likely are the protocols that you have in place, how likely are they going to work to prevent that error? And it's looking at things like look-alike, sound-alike drugs, training on new equipment, things like that. Medications that are required to be stored in a special way, hazardous drugs. Those are typically the kinds of proactive risk assessments that are done. Now, I strongly recommend that you complete a proactive risk assessment with your application to URAC. That then is something that they can then check off that it's done. If you haven't done it yet, I even strongly recommend that you create your template and at least submit that so that they know that you understand what the responsibilities are. Sometimes folks confuse the proactive risk assessment as your analysis that you've done when you have a big bad error. And that's not the intent. This is done just as the word suggests, proactively, helping to prevent some error from occurring. FEMA has a lot of resources. You can go out to, and I'll put this link for you on ways to implement the failure mode and effects analysis. It's www.ismp.org. I'll put the link for you here so that you have it. You can go there. There's a lot of information that's available. As I mentioned, those of you that have contracted with us, we have a risk assessment template. It's found in Goldfinch under the documents link in this standard, in the Pharm Op 15 standard.
Excellent. Thank you, Sue. We're getting toward the top of the hour, which is perfect timing because we have one more standard to cover. Leslie was going to take this, but her technical difficulties kept her off, so I'll take it. It's Pharm Core 41. This is for background screenings, and it's really speaking to 2 different clusters of employees. So I'll take them one at a time. 41A, it requires, first of all, it applies only to employees who have access to consumer personal health care information, so PHI or IIHI. If they, those employees who have such access must have a criminal background check done. So make sure you have a criminal background check for every employee who has access to consumer healthcare records. And then the second element within Pharm Core 41 is about, applies only to those members of your staff that have access to medications. Now we're going to put in a little caveat here about state regulations in a minute, but this is the URAC standard. So if a particular employee, even if it's not a part of their job to handle medications, if they have access to medications, then they need to go through drug testing and screening, and not just limited to illicit drugs. So do a kind of a full panel drug screen on those employees. Now, there are state regulations for this standard in particular that are more rigorous than that. In other words, might have a much broader implication in terms of who must go through either the criminal background check or the drug screening. So make sure that you have checked your applicable state board of pharmacy laws and regulations before developing your policy around this issue. Because as I'm noting, we've seen instances where the state regulation is more rigorous than that. So again, if you have access to, employees have access to consumer healthcare records and personal information, then that requires a criminal background check. And then second, if they have access to medications, then that's a drug screening. Let me check one more time to see if we have any other questions.
I'd like to add something to that.
Sure, please do. Please do.
We've noticed a recent trend when the URAC reviewers come that they actually want to see the results of the drug testing. It wasn't sufficient enough to be able to show that the drug testing was done. There are some state laws that prevent you from sharing that information, so you'll want to be aware of that and work with your without consent from the individual employee. So you may want to work that out ahead of time to make sure that you can demonstrate compliance with that to the URAC reviewer.
Excellent. Thank you, Sue. I'm noticing we're about 3 minutes from the top of the hour, so there are a couple of things I want to tell you about. First of all, let's see if this works. At the bottom of your screen, you'll see an opportunity to schedule a call with Sue, since the bulk of these issues are issues that Sue has the deepest experience in. If you click that button, it'll take you to a piece of software that'll allow you to schedule a call with Sue. That'll work, and it'll take care of time zone differences, so please take advantage of that if you have any follow-up questions. We do a webinar once a month. The next one will be January 30th. We haven't come up with a topic yet. Actually, we've come up with a lot of topics, but we haven't figured out which one of those we're going to do this month. And so we certainly encourage you to join us at 3 p.m. Eastern on January 30th. If you want to look at what we've done in the past, the webinars we've done in the past, what I've posted over in the chat column on the right is a link that will take you to all of our previous webinars that covered things like, covered issues like how to prepare for a URAC on-site visit to your pharmacy, quality improvement projects. We talked a little bit about QIPs today, but we've got a whole webinar about quality, which went into much greater depth than we did today. So we encourage you to do that. We're very, very grateful that you joined us today. It's always good to see our friends in the line of folks who are on with us, and so thank you for joining us. Do write to us. You know what? You can go to info. You can send an email at info@integralhs.com, and it'll come right to me. What did I leave out, Sue?
I don't think anything, Tom. I think we're good.
Okay, so I'll put info@integralhs.com in there. Again, that comes right to me. Thank you all so much, and I hope to see you next month on January 30th at 3 p.m. Eastern. Take care.
Take care, everybody. Happy holidays.